more. Today we are going to talk about ovarian reserve testing. What is it? How do we test for it? How accurate is it? And how do we as nurses, importantly, present the findings to our patients in an empathetic yet thorough way? So we're so excited. Our guest today is Dr. Ilana Ressler. Dr. Ressler is a board-certified reproductive endocrinologist at RMA of Connecticut. She received her undergraduate degree from Duke University and medical degree from Case Western Reserve University. She completed her OBGYN residency at the University of Illinois at Chicago and fellowship in reproductive endocrinology at the University of Cincinnati. So thanks for joining us today, Dr. Ressler. Thanks for taking time out of your busy day.
Of course, my pleasure. Happy to be here.
So before we discuss ovarian reserve testing specifically, can you give us a brief review of what happens in a normal menstrual cycle?
Of course. So this is, we've all seen this image a million times, the normal physiology, but it all, comes back to this diagram basically. So as we know, starting from puberty, every month there is a group of follicles available for use within the ovary. And of course, there's the hypothalamic pituitary ovarian axis, which is what really is the driving force behind the menstrual cycle. That nice cascade of hormones that talk to each other with feedback. So if we look at the top row in this slide, represents what happens throughout a normal 28-day cycle to a follicle. It develops until mid-cycle when that follicle releases the egg, which of course is ovulation. And after that, it becomes a corpus luteum and produces progesterone. So that row below it, we can see these fluctuating levels of the pituitary and ovarian hormones. And just to point out, we're going to come back and talk about particularly the follicle stimulating hormone, FSH, and we know that of course this is low, as all the hormones are at the start of a cycle, right? Day one, a full flow is cycle day one, and these all fluctuate throughout a normal cycle, which is important to put into the context of where a patient is in her cycle so that we can interpret these tests. And then the bottom part of that diagram represents what's happening in the uterus, specifically the endometrium. That again, as from the beginning, it starts by shedding each cycle and regenerates, and then it's receptive mid-cycle to receive an embryo for implantation. And finally, if not pregnant, the cycle starts over and it sheds again.
Perfect. And there's a finite amount of endogenous FSH that's produced each cycle too,
right,
which is then going to end up being important for follicular recruitment and development.
Exactly. It's really, that is the key hormone that we rely on for the follicular development. And of course, if we consider women with ovulation dysfunction, it's often because it goes back to these hormones and there's some sort of imbalance. For example, with PCOS, androgen, insulin plays a role, and these will interrupt this really fine orchestration of the hormones, and a cycle will then be abnormal or irregular.
So now we hear this term ovarian reserve. Can we kind of go over what that means with maybe in the context of discussing with us the continuum of reproductive aging? Like, what is reproductive aging? When do we have the most amount of eggs? What happens after that, et cetera?
Yeah, sure. So this is a really important concept for fertility. When we're evaluating someone's fertility, we're looking at all different aspects of their reproductive health, but one of the most critical ones is really what is their ovarian reserve. And this idea is based upon the principle that a woman is born with a finite number of eggs. So during fetal development, actually before the woman is born, when she's in her mother's uterus, she has the most eggs that she'll ever have. So it's thought to be up to about 6 or 7 million eggs during fetal development. Then by the time a woman is born, it's actually down to about 1 or 2 million. And then this number just rapidly declines throughout our life until menopause, when they're essentially all gone. So by puberty, it's about 500,000, and then we see the effect really starting, of course, well before menopause. By menopause, that's when the egg supply is depleted. So in the world of OBGYN, we know that 35 is this advanced maternal age, and that's when statistically there starts to be a detectable difference with the oocyte quantity and quality. So the idea of ovarian reserve is really, linked to this idea of reproductive potential based on the quantity of eggs.
Okay. And this happens most likely with advancing chronological age, but sometimes in spite of chronological age, which we'll get into later.
Mm-hmm. Mm-hmm. And right, it's again, it's a finite number of eggs that someone is born with, and the rate at which someone loses these eggs can vary individual to individual. So not all 30-year-olds will have the same ovarian reserve. Similarly, not all 40-year-olds will have the same ovarian reserve. We know, however, that the quality issue affects women universally. So, and we'll talk about that in a little bit, how it's, having poor ovarian reserve at an older age has a different meaning than at a younger age, for different reasons as well.
So when we talk about ovarian reserve, really what we're talking about is the quality and quantity of the eggs that that woman has at that moment of time. So if we consider the previous slide, we're taking sort of a snapshot of whenever we test that woman, and then it records where she falls along that continuum for her, personally.
Mm-hmm. Exactly. And there's no way to know, again, exactly how many eggs are left or to predict when a woman will go through menopause. But the key idea behind ovarian reserve testing is really to get like a general sense of where someone is in her ovarian reserve. Is it average? Is it what we would expect? Is it low or is it high? And this can really help us with counseling patients in regards to how aggressive should we be with our treatment, how we should dose medications that helps us, and certainly when there are extremes of these tests, then it could even advise us that their likelihood of success might be too low to even attempt the fertility treatments. Of course, that's the exception. But we also know that besides the natural progression of ovarian reserve decline that we see with age, there are certain factors that can also be associated with earlier loss of these oocytes. So, for example, if someone undergoes chemotherapy, if they have pelvic radiation, there are certain genetic abnormalities, for example, Turner syndrome, in association with Fragile X. Also, if someone has chromosomal mosaicism, all of these can be associated with a much earlier decline and potentially even a high risk or occurring premature ovarian insufficiency, which is by definition going through menopause before the age of 40.
And we'll talk about some lifestyle factors that are both detrimental and possibly protective. But the other thing that you as a physician would use this information for is maybe to detect what patients would elicit either a hypo or hyper response to medications. So you're going to counsel someone differently on cycle cancellation on one end of the spectrum, and maybe for the other end of the spectrum, you're talking to them about an alt trigger shot or Lupron trigger because of elevated levels, et cetera.
For sure, exactly. It helps us, not only with the big decision making about what treatment type to pursue, but also exactly these details that you're talking about. If someone has super high ovarian reserve, then they're of course going to be at much higher likelihood of having ovarian hyperstimulation, and just like you mentioned, doing a Lupron trigger, plan for that in advance. Or if someone is having, less of a response to a stimulation, let's say they only have 2 or 3 follicles that are developing. Well, if someone has really severe, very low ovarian reserve, this might be the best that they can do. But if we see that they have otherwise what we would expect to be good ovarian reserve, then we would say, you know what, this isn't a good cycle, let's cancel it and let's start again and try.
Right. And in terms of this graph, the one on the lower left, which is showing that the rate of spontaneous loss is elevated and the fertility rate goes down, and how this relates to ovarian reserve. Can you talk about that for a quick minute?
Sure. So, we mentioned how ovarian reserve is primarily relates to the quantity of eggs, but also quality is closely associated with age. And the quality of the egg and really the age of the woman is one of the biggest predictors of success, if not the biggest predictor of success with our fertility treatments. So, of course, as a woman ages, and we see, again, coming back to that advanced maternal age, starting at 35, that's when we start to see a shift in these graphs, and you can see that the rate of spontaneous abortion only increases from there. And again, with a woman in her 40s, the majority of eggs are going to be abnormal, so that's when that rate of miscarriage is really going to skyrocket.
Okay. So we test somebody for ovarian reserve, and we'll talk about the specific tests. But at some point, for a lot of our patients, unfortunately, they're diagnosed with something called diminished ovarian reserve. So what is that? Can you define that for us?
Sure. So this is a term that we use, very routinely, diminished ovarian reserve, or DOR, and it really describes a woman who is of reproductive age, who's still having regular menses, but who is likely to have a reduced response to ovarian stimulation or fecundity rate compared with women of comparable age. So this is, again, going back to that part, they're still having regular menses, so they're still, they're not in menopause, they're not in premature ovarian insufficiency, but they have lower ovarian reserve markers, and again, we'll talk about what specifically we're going to test for, but theirs are lower than what we would expect for their age. And of course, we know, again, universally, these markers are going to decline with age. So women, as they get older, will all decline. But is this what we would expect for a woman of that age, or is it lower than what we would expect?
And so there's certain limitations of this testing in a natural population or low-risk population. But what we know for sure for our patients, the ramifications would be a higher likelihood of a lower response to stimulating medications. So they would need to be on a pretty high aggressive protocol. A greater cycle cancellation, and a lower chance of pregnancy as compared to their age-related controls who have quote-unquote normal ovarian reserve.
Exactly. Yeah, so that's really where it could help us with counseling patients, is we want to make them aware of these risks, of course, before entering into a cycle. And this is sort of a theme that we'll talk about a little bit more, but I think that setting expectations is one of the most important things that we can do as providers when talking with our patients. We want them to really know what is their likelihood of success, or are they at higher risk of having a cycle be canceled, or being unable to really even create, get enough oocytes to give them a high likelihood of getting a good quality blastocyst. So I think setting these expectations from the beginning, even though it's hard news to deliver often, is really important, so that it's not a shock to them as they're going through and all of a sudden they see that they're doing much worse than what they had hoped, or maybe worse than their friend. Everyone's always comparing themselves to their friend who went through these treatments, even though, of course, we know that every woman is different and each situation is unique.
So let's pivot for a second and talk about women who are not necessarily infertile that are getting tested. Maybe they went to their OBGYNs, and you and I had talked about this prior to our talk here, that you get a couple of patients from an OBGYN who have a test that comes back gray area, slightly abnormal. And, panic ensues because now egg freezing and everything is in the news. So what does this mean for low risk populations? So natural fertility or patients who are not presenting to us in an infertility clinic?
Yeah, that's a great question. I think one that, is really evolving still because some of these tests are fairly new. Some of these technologies are fairly new. As you mentioned, egg freezing, relatively speaking, in the grand scheme of medicine, this is a very new idea and procedure that's being done. So the ovarian reserve testing is really a screening test, right? So with any screening test, there's going to be false positives. So when we're screening a large population of young women who aren't infertile, there's going to be a higher likelihood of having a false positive. And there have been some studies looking at what is, specific ovarian reserve markers for what is the meaning of those for women who are not infertile. And some say that you cannot draw a conclusion of or predict their future fertility based on these markers because they are different than the infertile population. Now, that said, I think that it is still meaningful information and shouldn't be ignored. It could be a warning sign or a red flag of future reproductive potential. And because we have this technology available and the ability to do something about it and preserve fertility, I think this is a good idea to at least explore for these women to see if that's something that makes sense for them.
But these levels need to be interpreted with caution, particularly in a young population, because lower or higher levels, depending on what we're testing, in a young woman don't necessarily have the same ramifications.
Correct. Exactly. They don't, imply the same thing because they haven't attempted fertility before. So it's hard to say. Again, we don't want to, brush it off and say and ignore it completely, and then they wait another 5 to 10 years, and then a woman is 43 and trying to attempt pregnancy for the first time. She's going to be in a much more difficult position just based on her egg quality, regardless of what her ovarian reserve is. So those are two things to keep in mind. It's not only the ovarian reserve markers, but we also have to keep the quality issue in mind. And we don't really have a good test for egg quality. Right, we can test embryos, we can do the pre-implantation genetic testing and see if an embryo is chromosomally normal, but we have no way of really looking inside and testing someone's eggs. So we have to really, again, go back to age as one of the biggest predictors of success and be proactive about someone's age and what their future family planning involves.
So let's talk about these tests. What are the tests that we use to measure ovarian reserve? And it sounds like the tests that we're going to be discussing then are much better at detecting the quantity then of the oocyte pool that's available as opposed to the quality.
Yes, exactly. So this is all, specifically about the quantity. And again, no specific numbers, no way to predict when is the supply going to run out, when will someone menopause, but or at least go through menopause. Exactly, but there's two main categories that we can think of it. One is biochemical tests. So this can be broken down into two categories. One is the basal measurements. The other is provocative tests. And then the other big category is ultrasonographic measures, or taking a look at the ovaries. And we'll go into that in a little bit more detail.
Okay, so let's take a look at some of these. Maybe you could review each of the following tests on this slide with us and their implications.
Sure. So one of the most commonly used tests is a basal follicle stimulating FSH level. And going back to, if you recall, with that first slide we looked at with the normal physiology, again, we expect these levels to be at baseline or at their lowest at the start of a cycle. So we ask a woman to identify when her cycle starts, again, reviewing with her that it's cycle day 1 is first day of full flow. And then we want to draw this FSH level on cycle day 2, 3, or 4. It's referred to as a day 3 FSH, but really we have a little bit of wiggle room, so it's okay if it's day 2, 3, or 4. We don't want to wait too much longer because FSH is going to start to increase, and as that cycle gets ramped up to try to recruit that follicle. So what are we looking for with the FSH level? Well, again, we're looking for those levels to be low. So what is the cutoff? We generally, all of these tests are assay dependent, and it's important to be familiar with your own lab and assay and what the cutoffs are for your specific lab. But just generally speaking, the universally accepted value is that the FSH greater than 10 is considered to be a sign of DOR. So we're looking for, again, that FSH value to be less than 10. When it starts to get into that like 10 to 13 or 10 to 15 range, that's starting to be, a warning sign that things are starting to change. And DOR is likely going to have an effect. And then as levels get higher and higher, of course, they may approach even menopausal levels. And then one really important factor to keep in mind is that we must have an estradiol level drawn at the same time as the FSH. And this is really important because, as we know, estradiol works, again, all these hormones are communicating with each other and giving feedback, and estradiol will suppress the FSH value. So if we have just an FSH value alone, let's say we have the value and it's a 7. Well, if we saw that, we would say, oh, great, she's normal ovarian reserve. But if her estradiol level was 150, then this would be suppressing her FSH level, and we would be falsely reassured. So that's why it's always important to have the estradiol level at the same time as drawing the FSH.
Because those two are inversely proportional.
Exactly.
Okay.
That must be a low estradiol, generally less than, anywhere from like 60 to 80. We want it below that level to correctly interpret the FSH. And so I would caution, we receive a lot of like outside records to interpret, and someone might have been sent to get some labs and they just have a random FSH value. It's important for us to say, we really can't interpret this because we don't know what the estradiol level was at that time.
Right. And somebody has a bad FSH, an FSH of 14 or 15 this cycle, and they say, I want to try again next month because maybe my FSH next month is going to be 9, and that's the month that we should cycle me. What are your thoughts on that?
Right. So that, some have suggested that might be useful, but really the data suggests that it's not. I've heard people say someone is only as good as their worst FSH. So really, even if their FSH is improved in a separate cycle, studies have shown that it doesn't improve outcomes. So it's really not worthwhile. In the meantime, of course, time is really precious. So we don't want to be watching, cycle after cycle go by to try to catch that good FSH level a month. So we really want to keep, again, time of the essence and move forward regardless. If you're going to go forward, go for it and not wait for a more optimal FSH.
Okay, and so AMH, our next one, I feel like over the last decade or so, we've heard more and more about this hormone. Can you discuss this with us? Sure.
So AMH, anti-Mullerian hormone, is a hormone that is secreted by granulosa cells of early antral follicles. So really, it's a direct marker of the number of oocytes in a way that someone has. So the more oocytes, the greater the AMH will be. And so unlike FSH, which will increase as ovarian reserve declines, the inverse relationship, AMH is, you can draw a direct relationship, and AMH will decline as ovarian reserve declines.
And we have a little chart here that talks about, at least in the lab that you and I use, normal values, although assays can differ. And so in this chart, it looks like an AMH, that's basically undetectable. So less than 0.3, at least with this assay, is concerning. Is that what most assays show, or what level of AMH are we concerned with?
Yeah, I think in general, we want to see it at least one, to indicate a good ovarian reserve. If it's less than one, then there's some indication of diminished ovarian reserve. And as you're saying, if it's less than, whatever the lab cutoff, so we'll never say it's zero, but if it says like less than 0.1 or less than 0.3, then that, as you're saying, really is undetectable. So that's obviously an extreme and a poor prognostic indicator. And conversely, if we look at the opposite end of the spectrum and we see a very high, this, again, as we mentioned before, can be important for us to dose the medications, and this will signal someone who might be at increased risk of OHSS. Of course, women with PCOS are going to have really high AMH levels, and we need to, keep that caution in terms of dosing and their medication.
Perfect. And then our last metric here, AFC, or antral follicle count.
Yep, so this is the one that we talked about using the ultrasound, and that is basically, we want to look, the best time to look is, again, at the start of a cycle. So when we're doing our day 3 blood work, we'll have a patient also get an ultrasound, and we're looking at the ovaries, and we want to see how many of those little antral follicles can we count. And antral follicles are defined as follicles that measure anywhere from 2 to 10 millimeters. And the best time is at the start of the cycle. So we look at each ovary and we count how many follicles do we see. So how many are optimal? Generally, we like to see at least 5 or so in each ovary. Some will say a total of, if it's less than 3 to 6, indicates poor ovarian reserve. And I would say of all of the markers of ovarian reserve, this one can theoretically be the most subjective, because there is some level of interpretation by the ultrasonographer, but if it's within experienced centers and experienced providers, then there's actually really good inter-observer reliability and unlikely to have drastic differences in these findings.
Great. So as a nurse, this is the hard part, I would say, for all of us, I would argue. So we get the patient's results off, and we're the ones relaying the information to them. And for many of us, when the results are abnormal or low, I think we want to say, call your doctor, meet with your doctor, and they should. But in the meantime, how best to deliver these results, at least in this limited way, before they have a full consultation with you?
Yeah, so this is definitely one of the harder things to do for nurses, doctors. No one likes delivering the bad news. We all like to get on the phone and give the positive pregnancy results to the patients. But I think one of the most important things is that we're honest. We are forthcoming with the information, and we give a clear explanation of what it means. So, again, it goes back to those expectations. So I think it's important to be upfront, to deliver the news. We can deliver it in a caring and an empathetic way. Certainly, being a good listener is, I think, just as important as relaying this news. And everyone takes it in a different way. Sometimes I'm surprised by, how well someone will take it, or conversely, we deliver a piece of news that we think isn't a big deal, and they think it's the worst news they've ever received. So everyone is different. We just need to be sensitive and listen to the feedback and the sense that we're getting from the patients, but again, to just be upfront and honest with the information. So I think that, what is the point of getting these results? It's not to say, give them an exact chance of success, or it's not the only piece of information that we're going to use for our reproductive planning or our treatment planning. It's just give, again, a general sense. Is it what we would have expected for their age? Is it lower? Is it higher? And this will help guide us not only with the medication dosing, but how aggressive should we be with our treatments? And should we, go straight ahead to the most aggressive treatment because it seems like all their markers are indicating really severe DOR? Or do we have a little bit more time and to spend in doing some maybe ovulation induction and give them an extra cycle or two if that's what works for that couple versus being really aggressive and going to an aggressive protocol with IVF.
And so you and I also talked about that you really need to consider this in the context of the patient's family planning goals. So when you first see a patient, even before these results come back, I know one of the common questions you ask them is how many children they desire. What size family are they looking to hopefully have? And so you would use that information then when counseling them once these results come back. This would just be part of that metric.
Exactly, because if someone, so it's sort of an odd question to have to ask someone, and most of the time they're just saying, well, we're just trying to, our focus is on just having one right now, we'd be happy with one. But really, most people do have an idea if they want, one, two, or if they say five, certainly that's a much different situation. And again, keeping in mind the patient's age and their ovarian reserve will help us with planning. So if someone is already in that advanced maternal age time frame and they don't have any children and they want to have three, well, then that patient might be best off cryopreserving embryos, banking embryos now, so they not only have a good chance of success at their current age, but it might be 5-6 years down the line before they're ready to have baby number 3. And so they'll be in that much better of a place at that time, as good of a place as they are now. So it is important to discuss that with the patient and see what their family planning is.
So I feel like what we're saying, just to emphasize this slide, because this is such an important slide for nursing, is to deliver the news thoroughly, sensitively, to really allow time in our busy day for this phone call, both to listen, to support the patient if necessary, to sort of expect any response, and particularly for those who seem great and then call back in 15 minutes, which we always have, and to really emphasize that these results need to be interpreted in a high-risk population. So what we can talk about is their response to fertility medications, not necessarily when they're going to reach menopause, et cetera. We would emphasize how we would expect them to respond in a treatment cycle.
Exactly. It's really, are we going to be more concerned or less concerned that they might be at higher risk of having a cycle be canceled due to a poor response of the medication? Again, it's going to help us with picking our protocol. So if they're moving forward with IVF, are we going to use a more aggressive protocol and medication dosing or less? And so it just helps with many of these decisions.
How can we treat this? This is the hard question, right? How do we treat or deal with this? This is such a difficult population and such a prevalent population in REI centers. What can we do in terms of maybe lifestyle choices, et cetera, supplements?
Right. So, the bottom line is there's probably little to do. There's little control that we have over it. There are some smaller things that may make a difference. One is, of course, to avoid smoking. So there are studies that show that smoking has a detrimental effect on ovarian reserve, that women who smoke will go through menopause at an earlier age. So that's one thing that is easy to counsel patients about smoking cessation. And of course, a healthy lifestyle is always going to help with fertility. Eating well, being cognizant of nutrition, exercise. I always emphasize the healthier someone is, the better their chance of success will be, and the healthier their pregnancy will be. However, it's also difficult because some women feel, well, they take impeccable care of themselves. They are always following really great nutritional guidelines. Maybe they're exercising 5 to 7 times a week, and they feel that because they've been doing things that their ovaries are somehow preserved, that their ovarian reserve should be better because of doing these things. And unfortunately, that's just not the case. So there are certainly limitations to what these lifestyle behaviors have. In terms of supplements, there is coenzyme Q10, which is an antioxidant, and this can be used for a wide array of reasons. And one is for fertility. There are studies that show that it can have an impact on the oocyte quality. So we do counsel our patients to take coenzyme Q10, and this can potentially have a beneficial effect on their cycle outcomes. Another one that has been studied is DHEA. This is an androgen. We know that this declines as a woman ages, so some have suggested that supplementing with this may also help with the ovarian reserve levels. And then, of course, it's important just at baseline for everyone to be on a prenatal vitamin. We want folic acid levels, of course, to be adequate. Vitamin D, there are studies showing that vitamin D levels have implications with fertility. So these are just some of the basics that we want to cover with all of our patients.
And we used to super ovulate the crap out of these patients. Like, let's see how many follicles we can get, because the more we have, the more sort of cushion we have in terms of fertilization and implantation and chromosomally normal embryos. But there's some emerging evidence that mini IVF can have comparable rates as conventional IVF without the detriments, side effects, cost, etc.
Yeah, this is really a topic of importance right now because some centers are giving all of their focus to mini IVF or even natural cycle IVF, and this goes back to the idea that women with diminished ovarian reserve might not respond to the medication. So I think that the idea that the more eggs we have, the better is still an important one, because especially with the oocyte quality it being an important factor, if we have more, there's more likely to be a good one among it. But for someone who might not respond well to the higher doses, it might not make a difference whether they receive, a total of 450 units of gonadotropins versus just some Clomid and maybe 100 units. They might have, in either situation, their maximum potential might be to just have 1 or 2 follicles, or maybe 2 or 3 follicles develop.
Right, and then we're not canceling them. So let's say our parameter at our center is to have 4 follicles in order to go to retrieval. With mini IVF, the tolerance for that is much lower, so they at least get a chance that month.
Exactly. And again, this goes back to the expectation. So I think that as long as you counsel a patient, what are the risks of going to retrieval? There's a chance that we might not get an egg out of a follicle. So if they only have 2 dominant follicles, at best, we're going to get 2 oocytes, and they have to understand that there's a possibility we might get 1 or even none. And if everyone is comfortable, then I think that everyone deserves a chance of going forward with that.
So let's assimilate or highlight some of this data by using a couple of case studies that you so kindly put together for us. Can you discuss patient Emily with us?
Sure. So patient Emily is a 35-year-old G0 single female who does desire future fertility. She has a history of irregular cycles when she was a teenager. So she's been on birth control pills since the age of 16. She has a past medical history of anxiety, no surgical history, meds. She's only on her OCP. She's on a multivitamin. Really nothing else of significance in terms of her history. But so this patient is really considering what are her options for future fertility. She's at this age of 35, which is starting to be the advanced reproductive age, and she wants to know, should she consider freezing her eggs or not.
And what did you find in terms of her testing?
Yeah, so the first thing, of course, with the initial visit, we wanted to do an ultrasound. And at this initial ultrasound, we saw that she has quite small ovaries bilaterally with only about 2 to 3 antral follicles on each side. So that's sort of the first red flag that we come across. It could be, again, at this initial visit, you don't even have any other information, no FSH, no AMH, but right off the bat, you notice that there's something that looks a little bit different in terms of her ovaries and the antral follicle count. Then you order the rest of your ovarian reserve testing. So for this patient, we ordered her AMH. It came back at 0.13, so really approaching that undetectable level. And then we wanted to see what is her day 3 FSH. So this can really, I think, help make a difference. If we see that her FSH is still normal, that's going to provide us with some reassurance that she might not be as far along with her diminished ovarian reserve. But if we see that her FSH is 18, for example, then that's going to really be more cause for concern. So in this patient, we saw that her FSH was 7.9, her estradiol level was 49, so still in the normal range with her FSH.
And what did you end up doing for her with this information?
So we discussed that her ovarian reserve was consistent with DOR. So both the antral follicle count as well as the AMH were consistent with DOR. And for her, she did desire to have at least 2 future children. Again, she's single. She's not in that committed relationship that she's looking for before pursuing her family planning. And so it was important to really strongly consider oocyte cryopreservation to give her potentially a better chance at future fertility. So she did end up going through a egg freezing cycle, and we did use a very aggressive protocol, maximum dosing, total of 450 units, used a microdose Lupron flare protocol, and she was able to cryopreserve 6 oocytes from that cycle. And she is planning to do an additional cycle to just add more to that reserve.
So this information was really helpful for her because as a single woman, she is deciding at this point to dedicate her financial resources to, preserving potentially her reproductive potential in this case. So had she not had this information and she found this out when she was 37 or 38, maybe she would have been more limited.
Yeah, exactly. That's why, even though, as we said, there's limitations to using this testing in a fertile or at least not a proven infertile population, we still heed the warnings and be proactive. And just like you said, this woman is going to be in a much better place, potentially when she's 38, trying to have her first baby, and then let's say she's 42 and wanting to have her next one. At least she has these eggs, which are frozen in time, so to speak, and will be of the quality of a 35-year-old even when she is biologically 42.
Right. So the next person is Laura.
Right. So patient Laura, a little different situation. She's 41, G1P1. She is desiring to have baby number 2, and she's been trying to conceive for 6 months without success. So this would be secondary infertility. She still has regular monthly cycles, some medical history of being hypothyroid. She's had an appendectomy, and nothing else really out of the ordinary with the rest of her history. So with Laura, when we did her initial ultrasound and looked at her ovaries, they appeared normal in size, and she had a total antral follicle count of 13, which, as we talked about, we want to see at least, a total of at least 3 to 6, and she had 13. So really, in a very good situation or position in terms of the antral follicle count. Then we went on to do the remainder of her ovarian reserve testing. We found her AMH is 1.9. So again, very good news. She still has a normal AMH, and her day 3 FSH was 7. Her estradiol was 56. So This gives us some insight, again, for planning what her treatments will be. Now, she's still 41, so we still have that oocyte quality issue to overcome. And for that reason, this patient ultimately decided to do IVF with pre-implantation genetic testing to then test the embryos to see which ones are chromosome normal to help her select the best embryo and increase her likelihood of having a live birth.
So I'm glad that you mentioned that she's still 41, because we as nurses would give this information, and then a patient like this would be very likely to say, oh, I have the ovaries of a 35-year-old. And, no, not necessarily, because she has normal ovarian reserve parameters, but is still 41 years old. So, in a respectful way, it's still important for us to, convey that information.
Exactly. I mean, she's certainly in a better position than a 41-year-old who has, an antral follicle count of 4 with an AMH of 0.2. But you're right. You're exactly right. She's still the biggest hurdle for her is going to be getting that chromosomally normal embryo.
Right. So the comparison for her is not comparing herself to a 35-year-old. It's comparing herself to a 41-year-old who potentially doesn't have normal results. It's a different context.
Yes. Yeah.
So this was so great. I think it really gave us some working information on this really kind of nuanced subject for us. So you want to go over these conclusion points with us to final?
Of course. Again, going back, there's no single test that can predict reproductive outcome. So, I always say I wish I had my crystal ball and could tell you exactly, how and when someone is going to be successful with treatments, but there is not one single predictive test that can tell us this. But ovarian reserve can certainly help guide us in many ways, as we've talked about today. There are different tests available. We've highlighted the most important ones, most useful ones, the basal FSH and estradiol, the AMH, and the antral follicle count. And then importantly, as we touched upon, delivering bad news. So it can be very devastating for patients. It can be stressful as providers, but just taking the time, being sensitive, delivering the news in a straightforward, honest, but caring and empathetic way, I think is really important. And lastly, DOR is something that we help patients deal with on a daily basis. And at this point, there really is no single treatment for it. I think that a key is to be aggressive. We don't want to tell a patient, think about it, come back to us in 6 months or 9 months when you're ready. We want to emphasize, time is of the essence for these patients, and we want to be aggressive in treating their DOR.
Perfect. Thank you so much for joining us today, Dr. Ressler. I think this is incredibly valuable information, and we really appreciate your time.
Of course, my pleasure. Thank you for having me.